Hello friends, myself Meenu and we are going to continue part 3 of this series, the skeletal system, and we are going to continue and discuss about joints of upper extremities. So let's start this and in this we will discuss about joints of shoulder girdle and in the hand, elbow. So let's see, these are, first of all let's see our topics. Regarding the topics, these are joints of shoulder girdle, other joints of upper limb, and third, muscles producing movements. And now about shoulder girdle. The shoulder or pectoral girdle connects the bones of upper limb with axial skeleton, and the girdle consists of clavicle and scapula. Shoulder girdle, also known as pectoral girdle, also known as pectoral girdle, and this connects the bones of the upper limb with axial skeleton. The girdle consists clavicle, scapula, and let's see sternoclavicular joint. And here we can see sternal. This is the sternum bone, and here is the clavicle. When the clavicle bone and sternum bone fuses together, makes sternoclavicular joint. Okay. The scapula has no direct connection with the axial skeleton, but it attached to the latter only by muscles. So sternoclavicular joint is a saddle type synovial joint. Which type? This is a saddle joint. This is a saddle joint, and it is formed by sternal end of the clavicle and clavicular notch of manubrium sterni. This is the manubrium sterni, and this is the sternal end of the clavicle. The joint cavity is completely subdivided by a fibrocartilaginous articular disc which fuses with the capsule anteriorly and posteriorly. Joint cavity is completely subdivided by fibrocartilaginous articular disc which fuses with the capsule anteriorly and posteriorly, and this fuses with the capsule anteriorly and posteriorly. So sternoclavicular joint is a type of joint, saddle joint. And now AC joint. AC means acromioclavicular joint. It is a plain synovial joint. Here we can see AC joint. This is the acromion process, and this is the clavicle, and this joint known as acromioclavicular joint. This is a type of plain synovial joint. Plain. Bone forming the joint are the lateral end of the clavicle and clavicular facet on the medial margin of the acromion process of scapula. Here is the lateral end of clavicle involved and clavicular facet of the medial margin of acromion process of scapula. The main bond of union is coracoclavicular ligament. Here is the which ligament involved? Coracoclavicular ligament, which has two parts, conoid, its medial, and trapezoid, its lateral. The weight of the upper limb is transmitted to the medial two-thirds of the clavicle and thence to the axial skeleton through the coracoclavicular ligament. And here, write a point, that is, the weight of upper limb is transmitted to the medial two-thirds of the clavicle and thence to the axial skeleton through the coracoclavicular ligament. Okay. Then the movements of the shoulder girdle. Both acromioclavicular and sternoclavicular joints allow gliding, translatory and rotatory movements of scapula. Gliding also known as translatory and rotatory movements of scapula. The scapular gliding includes elevation, depression, protraction and retraction, and scapular rotation may be forward or backward as expressed by movements of inferior angle of scapula. So here is the list of the movements. Elevation muscles causing movements: trapezius upper part, levator scapulae. Then depression, pectoralis minor, serratus anterior. Protraction, serratus anterior, pectoralis minor. Retraction, rhomboidus major, rhomboidus minor. Forward rotation of inferior angle for overhead abduction. This includes trapezius upper fibers, serratus anterior lower fibers. And then backward rotation, levator scapulae, rhomboidus major and minor muscles are included. So now shoulder joint or glenohumeral joint. This is a ball and socket joint. This is a type of ball and socket joint between head of humerus, which is like a ball, and glenoid cavity of scapula, that's a socket. Here you can see in this picture. Yeah. So here is this glenohumeral joint. This is the ball and this is the glenoid cavity of the scapula. So this is ball and socket joint. It is a multi-axial joint and it's a multi-axial joint. Multi-axial joint and enjoys considerable range of movements at the cost of stability. This joint is weak because the head of humerus is 3 to 4 times larger than the shallow glenoid fossa. This is the this ball is the 3 to 4 times larger than the shallow glenoid fossa, and stability of shoulder joint is provided by rotator cuff and here we can see stability. First of all, write a heading: stability to shoulder joint is provided by, first of all, rotator cuff, This is a musculotendinous cuff. This is a musculotendinous cuff, and it is formed by blending of tendons of supraspinatus. This is by the blending of the tendons of supraspinatus superiorly and let me make this supraspinatus superiorly and infraspinatus inferiorly, and teres minor posteriorly. Teres minor, this is posteriorly, and subscapularis anteriorly, and this is the subscapularis, this is anteriorly. So inferiorly capsule is loose and lax and the joint is least protected here, as there is only one muscle crossing the joint inferiorly, long head of triceps. So this is least protected. And the second point is tendons of long head of biceps passing above the head of humerus intracapsularly prevents upward displacement. So second point is tendons of long head of biceps passing above the head of humerus, the head of humerus intracapsularly intracapsularly, prevents upward displacements, prevents upward displacement. Okay, and now coracoacromial arc formed by, third point is coracoacromial arc formed by coracoacromial ligament connecting coracoacromial ligament connecting coracoid and acromion process with each other, protects the joint from above, and this protects the joint from above. So there is two important points also. Among the four muscles of rotator cuff, subscapularis is also called as forgotten muscle in rotator cuff. So here is the subscapularis, which is called forgotten muscle. Most commonly injured muscle of the rotator cuff is supraspinatus. Most commonly injured muscle of rotator cuff is supraspinatus. Now we will study about bursae around the joints. There are following bursae around the shoulder. Number 1 is subacromial subdeltoid bursa. Subacromial, also known as subdeltoid bursa. These are usually continuous with each other. These are usually continuous with each other, and it is one of the largest bursa of the body. Largest bursa of the body. Which is the largest bursa of the body? Subacromial subdeltoid bursa. So it separates coracoacromial arc and deltoid muscle from supraspinatus tendon and joint capsule. So it separates coracoacromial arc and deltoid muscle from supraspinatus tendon, and joint capsule. And now in this, the point number 2 is this bursa, subacromial and subdeltoid bursa, facilitates abduction. This facilitates abduction, and during this movement it moves beneath the acromion process. It moves beneath the acromion process, and in subacromial bursitis, if the inflammation of this happened, so this is known as subacromial bursitis. Pain is allocated. Pain is elicited when the deltoid is pressed just below. When deltoid is pressed just below the acromion process, the acromion process, and the arm being in adducted position, and the arm in the adducted position, and when the arm is abducted to 90-degree, pain cannot be elicited. When arm is abducted 90-degree, pain cannot be elicited by pressure on the same point, because bursa disappears under the disappears under the acromion. So now this is called Doburn sign. This is called Doburn sign. And now this second bursa around the, let me erase this. Now second bursa around the shoulder is subscapular bursa. Subscapular bursa, and it lies between anterior capsule and subscapularis muscle. Anterior capsule and subscapularis muscle. It is always in continuity with the joint cavity. Always in continuity with the joint cavity. And now the third bursa is infraspinatus bursa. So here third bursa is infraspinatus bursa. So it lies between posterior capsule and infraspinatus tendon. This lies between posterior capsule and infraspinatus tendon. Sometimes it may communicates with joint cavity. Sometimes it may communicate with joint cavity. And now let us see this figure. Here you guys can see that this is the clavicle, coraco-clavicular ligaments. These are, here you can see coracoacromial ligament, and this is the acromioclavicular ligament. This is the acromial process, and here is the subacromial bursa. This is the subacromial bursa, and this is the subdeltoid bursa, and tendons of supraspinatus muscle, transverse humeral ligament, tendons of subcapsularis muscle, tendons of biceps brachii muscle, humerus subscapularis bursa, scapula, glenohumeral ligaments, articular capsule. This is, and this one is coracohumeral ligament. This is subcoracoid bursa. This is coracoid process. So our picture is finished. This is the anterior view of the shoulder, and now we have to see the movements around the shoulder joint. Active movements permitted at shoulder joint are flexion, extension, abduction, adduction, circumduction, medial and lateral rotation. Flexion, extension, abduction, adduction, and medial rotation, lateral rotation. So the movements are analyzed with reference to the body of scapula. These movements are analyzed with reference of the body of scapula. Unlike conventional plane of trunk, the flexion and extension takes place at right angles to the plane of the body of scapula. So abduction and adduction take place parallel to the plane of the body of scapula. And now here we can see that muscles which are included mainly clavicular head of pectoralis major, anterior fibers of deltoid, and accessory muscles are coracobrachialis, short head of biceps, sternocostal head of pectoralis major. And in the extension, posterior fibers of deltoid, latissimus dorsi are major muscles, and teres major, long head of triceps are minor muscle. And in the adduction, pectoralis major and latissimus dorsi are the major muscle, and teres major, coracobrachialis, short head of biceps and long head of triceps are minor muscles. And these teres muscles is important because it has come in prior examinations also. And now abduction, it includes deltoid, supraspinatus, serratus anterior, upper and lower fibers of trapezius. and this is very important, also very important for your exam point of view. And now medial rotation. Here major muscles are pectoris major, anterior fibers of deltoid, latissimus dorsi, teres major, and minor muscle is subscapularis. And this is also very important. And for the lateral rotation, posterior fibers of deltoid, infraspinatus, and teres minor. These are major muscles which are including for the lateral rotation of the shoulder joint. And now subhumeral scapular humeral mechanism. So movement at the shoulder joint occurs not only at glenohumeral joint but is also contributed by rotation of scapula on thoracic wall. So in abduction, out of total 180-degree elevation, when we are doing abduction, out of total 180-degree elevation, humerus moves 120-degree. Humerus moves 120-degree at the shoulder joint. Of the remaining 60-degree is done by rotation of scapula, and here is the scapular rotation is 60-degree. So in every 15-degree elevation, shoulder joint contributes 10-degree and scapular rotation 5-degree in the ratio of 2:1. So rotation of scapula is facilitated by movements of sternoclavicular and acromioclavicular joint. So here the movements of scapula are facilitated by which joints? Sternoclavicular and AC joint. In higher ranges of abduction, there is lateral rotation of humerus. Lateral rotation of scapula increases the range of humeral elevation. And abduction is initiated by supraspinatus, which is responsible abduction up to 15-degree. This is very important point. You should note this down. So just write the point. Abduction is initiated by supraspinatus muscle, which is responsible abduction up to 15-degree. This also have come in AIMS 93. After that, deltoid, acromio or middle fibers is major abductor up to 90-degree of abduction. Which is doing 90-degree abduction? This is deltoid, acromial or middle fibers. Acromial or middle fibers. So is the major abductor. This is the major abductor. These two muscles, supraspinatus and deltoid, are prime movers for abduction. Overhead abduction more than 90-degree is caused by trapezius. And the third point to be noted here, if overhead abduction is happening more than 90-degree, then it is caused by trapezius muscle. Which muscle? Trapezius and serratus anterior and serratus anterior. which act by causing upward rotation of glenoid cavity, which act by causing upward rotation of glenoid cavity. And now some very important points which are also very important. Now painful arc syndrome is characterized by pain during mid-range of abduction 60 to 120 degree with freedom from pain during initial and terminal stages. This can be produced by minor partial tear of supraspinatus and supraspinatus tendon inflammatory degeneration, supraspinatus tendonitis, and calcific deposits in supraspinatus. So spinatus tendons and subacromial bursitis or greater tuberosity fracture. So painful arc syndrome is characterized by these 5 symptoms. And now shoulder joint is commonest joint in human body to dislocate. So which joint is the commonest joint to be dislocated is the shoulder joint, and anterior dislocation is the most common. Which is the most common is the anterior dislocation, and this is come in SGPGI 93 exam and UP 98 also. Complete tear of supraspinatus is characterized by inability to initiate abduction. What further abduction is possible if limb is abducted passively to 15 degree. Okay, and now move ahead to the other joints of the body. So now here we can see this is the elbow joint. Elbow joint. This is the humerus and here is the radius ulna, and this is the coracoid fossa. Here is the capitulum. This is the lateral epicondyle, medial epicondyle. This is the trochlea, and here is the head of radius, coronoid process, and this is the bicipital tuberosity, and here is the olecranon process of ulna. This is posteriorly, and this is the olecranon fossa. Here is the lateral epicondyle, and we have done with this. This is the anterior view, front, and this is the posterior view. And elbow joint is a type of hinge joint. Which type of joint? Elbow joint is a type of hinge joint, and this is composed of humero-ulnar trochlear notch of ulna with trochlea of humerus and humero-radial head with capitulum of humerus articulations. Let me erase this first. And now this is composed of humero-ulnar and humero-radial. humero ulnar, which is trochlear notch of ulna with trochlea of humerus, and humero radial, which is radial head with capitulum of humerus articulations. Joint is established by radial collateral ligament laterally by radial collateral ligaments, these are laterally, and ulnar collateral ligaments medially. Then ulnar collateral ligament is closely related to ulnar nerve. These are also closely related to the ulnar nerve. And the movements at elbow joint are flexion and extension. Movements at the elbow joint are which? These are flexion and extension. Here is the lateral view of the elbow joint. This is the olecranon of the ulna. This is the radius bone. This is the cartilaginous loss. When this happens, bones press humerus narrow joint space. This is a condition of a disease. And now movements at elbow joint. These are flexion and extension. Flexion including muscles causing movement. These are primary muscles brachialis, biceps. Biceps acts best in supination. Which muscles acts best in supination is the biceps, and brachioradialis acts best in mid-prone. And supportive muscles are pronatus teres and flexor carpi. This is very important. Now in the extension, triceps and anconeus muscles are included. Note all the muscles which arise from medial epicondyle cross elbow anteriorly act as V flexor of elbow joint. Thus palmaris longus and flexor carpi radialis, humeral head of flexor carpi, ulnar flexor digitorum, suprafacialis sublimbus and pronator teres are weak flexor of elbow forearm. These all are muscles of anterior superficial flexor compartment. Okay, now let's move to the some also very important point. In the student's elbow, minor's elbow is inflammation of olecranon bursa known as olecranon bursitis, and pulled elbow or Nesmet's elbow is subluxation of radial head, and elbow dislocation is common in anterior direction, posterior dislocation, and carrying angle is formed between the upper arm and forearm when the elbow is extended and forearm is supinated. The normal carrying is 163 degree. Normal carrying angle is the 163. Some books gives a value of 11 degree for male and 14 degrees for females. It is more in females. Carrying angle disappears in full flexion of elbow and pronation of forearm. Cubitus valgus is an increase in carrying angle. Cubitus valgus is an increase in carrying angle, and the cubitus varus is an decrease in carrying angle. Okay. Now let's move ahead to the radioulnar joint. The radius and the ulna are united by three radioulnar joints. Superior or proximal. This is the proximal radioulnar joint. Proximal radioulnar joint. And this is the superior. Here is the middle radioulnar joint. Middle radioulnar joint. This is the middle, and the inferior. This is the distal radioulnar joint. Distal radioulnar joint. This is the inferior, whereas the superior and inferior joints are synovial joints. These superior, proximal and distal are synovial joints, and the middle is the radioulnar joint. It is syndesmosis type of fibrous joint. This is the syndesmosis type of fibrous joint, and for the this proximal radioulnar joint is a pivot joint. This is a pivot type of joint, and this is a synovial joint between the circumference of head of radius and radial notch of ulna. This is the radial notch of ulna, and this is the head of radius. So here is the proximal radioulnar joint, and in the middle radioulnar joint, this is a syndesmosis type of fibrous joint. Which type of? Syndesmosis. Okay. Formed by interosseous membrane connecting the shafts of radius and ulna. Let me raise this. Now. And this is formed by interosseous membrane connecting the shafts of radius ulna. This is the membrane connecting the shaft of radius and ulna. And the distal radioulnar joint is also pivot joint. This is also pivot type of joint, and also synovial joint between head of ulna and ulnar notch of radius. Between head of ulna and ulnar notch of radius. So movements of radioulnar joints are pronation and supination. There is the two movements possible for this joint. These are pronation and supination. Pronation includes muscles are pronator quadratus, strong pronator, and pronator teres, rapid pronator. And supination, supinator when elbow is extended, biceps when elbow is flexed. So this is how supination happened, and this is how this position is known as pronation. And the biceps brachii is the strongest supinator of the forearm because of its distal attachment on the radial tuberosity. First of all, let me erase this mess and write a point. Write a point that biceps brachii. Biceps brachii is the strongest supinator of the forearm. This is the strongest supinator muscle of forearm, and because of its distal attachment on the radial tuberosity. This is because of distal end attachment of radial tuberosity. So now let's move to the radiocarpal joint, wrist and midcarpal joints. So here is the radius, this is the radius, this is the ulna, and these are the carpals. So this joint is known as radiocarpal joint, and joint between the carpals, between this carpal and this carpal, is known as midcarpal joint. So wrist is a biaxial ellipsoid type of joint. Wrist is the which type of joint? Biaxial ellipsoid type of joint, formed proximally by distal end of radius and formed proximally by the, here is the distal end of the radius and articular disc articulating distally with scaphoid. Here is the scaphoid involved, and lunate and triquetral bones. Lunate, triquetral, these bones are involved. And midcarpal joint is formed between proximal and distal rows of carpal bones. So here is the proximal row and this is the distal row, and the joint between these is midcarpal joint. So the movements involved here are flexion, extension, adduction and abduction. So these movements are flexion, extension, adduction and abduction. And let's see joint, wait, movements. This is how the extension happened. This movement is known as flexion. When this movement happened, this is in some known as extension, but when this side it's radial deviation, when this side this is ulnar deviation. And when we do this type movement, this is pronation and this is supination. And now flexion. Flexion is a radiocarpal and midcarpal joint, and it includes muscles flexor carpi radialis, flexor carpi ulnaris, palmaris longus, assisted by flexor digitorum superficialis and profundus, and flexor pollicis longus, muscles of anterior compartment of forearm. And the extension includes the wrist extensor carpi radialis longus and brevis, and extensor carpi ulnaris assisted by extensor digitorum, extensor pollicis longus and extensor indicis and extensor digit minimi, muscles of posterior compartment of forearm. And adduction, also known as ulnar deviation, includes wrist. This includes flexor carpi ulnaris and extensor carpi ulnaris. And abduction radial deviation, this is the for the limited range and mainly occurs at mid-carpal joint. And this is flexor carpi radialis, extensor carpi radialis longus and brevis, and abductor pollicis longus, extensor pollicis brevis. Now move ahead to the carpo-metacarpal joint of the limb. This is the thumb joint. This is the joint CMC joint. So now this is the type of saddle joint. Which type of joint? Saddle type of joint between base of first metacarpal. This is the base of first metacarpal and distal surface of trapezium. This is the distal surface of trapezium. It enjoys greater freedom of movement. Here is the great freedom of movement. And movements at this joint are flexion, extension, abduction, adduction and circumduction. Circumduction includes 360 of rotation. Circumduction includes 360 rotation. And now let's see main movements of this joint. This is the extension when go outward. Also this is the opposition. This is the adduction when it comes to the joint, and when goes away it's abduction. So radial abduction. Now wait, for this, whether I have added table or not. For this flexion, main muscles are the lumbricals and interossei, and supportive muscle of the flexor digitorum profundus and superficialis. And for extension, this is for the metacarpophalangeal joint. I have not added a chart for this. Okay, wait, I'm just writing this. I'm writing, you guys can note from here. Flexion muscles. For the flexion, main muscles are flexor pollicis brevis, and opponous pollicis, and the supportive muscles for the flexion is flexor pollicis longus, and for the extension is the extensor pollicis brevis and extensor pollicis longus and abductor pollicis longus. Abductor pollicis longus. For the abduction, these are include abductor pollicis brevis and abductor pollicis longus. For adduction, it includes adductor pollicis muscle. Okay, so now let's move ahead to the next is the metacarpophalangeal joint, and this is a type of ellipsoid joint. This is also a type of ellipsoid joint between head of metacarpal and base of proximal phalanx. Between head of, these are head of metacarpals and base of proximal phalanx. So this is the joint known as metacarpophalangeal joint. And movements at metacarpophalangeal joints are flexion, extension, abduction and adduction. Flexion, extension, adduction and abduction. So now let's see the movements. For the flexion, main muscles of lumbricals and interossei, and supporting muscles are flexor digitorum profundus and superficialis. For the extension, main muscles of extensor digitorum and supporting muscles are extensor indicis for index finger and extensor digiti minimi for the little finger. And for the adduction, palmar interossei is the main muscle, and for the abduction, dorsal interossei is the main muscle. And now important fact is metacarpophalangeal joint is functionally an ellipsoid type of joint, and it is condylar joint structurally. In the structure, this is a condylar type of joint. Okay, so this is the interphalangeal joint, and this is a hinge type of joint. Which type of joint? Hinge type of joint between distal end of phalanx and proximal end of the other. This is the distal end of phalanx and proximal end of the other phalanx. So this is the proximal interphalangeal joint. This is the distal interphalangeal joint. Okay, this is the distal phalanx, this is the middle phalanx, this is the proximal phalanx, this is the metacarpophalangeal joint, this is the metacarpal. And how is this? This is the flexion happen, this is the extension, and now when this type is happening, this is the flexion. So interphalangeal joints are two in each finger except in thumb, where there is only one interphalangeal joint. In the thumb there is the only one interphalangeal joint. Here you can see this is the interphalangeal joint, but in the finger there is a proximal and distal two interphalangeal joints. Thus, each finger has these joints including flexion and extension movement. Flexion for the thumb finger. For the thumb finger, no extension can be happened, and extension for the thumb finger is included extensor pollicis. Here we can see the joints movement. This is the flexion. Thumb finger is flexor pollicis longus, flexor digitorum superficialis, and flexor digitorum profundus for distal interphalangeal joint. Extension for the thumbs is extensor pollicis longus, and for the fingers extensor digitorum for proximal interphalangeal joints, and lumbricals and interossei for distal interphalangeal joints. So now we are done with this series. This is the summary. We can revise from here. This is the trapezio metacarpal joint. This is the trapezio, and this is the metacarpal joint. Okay, and also known as CMC joint, metacarpal joint, thumb joint. This is the metacarpophalangeal joint, interphalangeal joint, proximal interphalangeal joint, and distal interphalangeal joint. So like, share, subscribe. Thank you. Bye bye. And if you guys like this and found this useful for yourself and your friends, family, so just subscribe my channel, and see you soon with another informative video. Bye bye. See you soon. Thank you.